the brace, Rob, I'll show you the features. So we're looking for, the measurement would be the, in this case, push more firm there for me, Rob, because that's not bent for you yet. So that would go suprasternal notch. In this case, we would go down to pubis, which we're not fully adjusted for the model today. But that would be going down a little bit further down to pubic level, would be getting the brace that little bit longer. The strapping session again on the back of the brace is similar to previous braces. It has a long strap with an adjustable Velcro, turn to the side up for me, adjustable Velcro tab, so that the brace can be adjusted, fitted to the patient properly. The strap length can be trimmed to an optimum level, so we've not got buckets of strap lying around in the place. Again, we've got the back pad in a position where it can be rotated to be vertical or horizontal, depending on the patient comfort. Horizontal is probably the best in most times because that takes in a flexi pad over the spinous processes, where the pad is a 6mm pad with a gap in the middle, with a pad over the top of evozote, which will mold to the patient. And as you can see, the central area will deform and sink to the pressure of spinous processes over that area. So very good with anybody that's got a bit of arthritic areas and discomfort over the spine. You could get much more comfort putting it in a horizontal position than vertical, because vertical would cover less area. So we're going to just fit this on you, Rob. We've pre-adjusted it. There's a quick release clip here. The patient, under normal circumstances, and then we pull the lever, lock off, sorry, Rob, there's a quick release clip on the side to lock it off. If the patient, once it's adjusted, if the patient goes with the brace and is allowed to start to remove the brace, if it's a stable fracture and the final session of healing, the consultant might downgrade them to wearing the brace less and send them home, of course, safely. And they could, in fact, put the brace on and off themselves, and the patient would pull the clip on this side and simply pull the clip on this side to remove the brace. So there literally is a very simple clip release system which locks in, pulls down, and has a tab on for little arthritic hands if there's any arthritis in the hands, or function of the hand reduction in power. There's a nice pull cord on this side for that. So there are the three models of the brace, and as I mentioned, they all cover and do the same job. The main difference is the bottom end pubic pad that would be the difference for different reasons, BMI index being the biggest one, and comfort of the patient, and what's fitting the best on the patient and comfortable in that area. Again, we're sending the patient to sit in a firm chair because they've got to have that pelvic band or pubic pad very low down to get maximum control for the length. So again, we're looking at firm chair sitting, that sort of thing. And very often we're looking at a rehabilitation of 6 to 12 weeks in a brace. So it's not usually the long-term brace that patients are actually wearing. Normally it's 6 to 12 weeks for various spinal issues, including those we mentioned, those stable fractures, and any post-operative, quite common in post-operative situations for spinal surgery of any form, to pop one of these off, because of course you've got a nice big open vented area for that. So these are used quite commonly post-operatively on the wards with patients